Greetings, vocational nursing students. Welcome back. This is week 3 of LVN 110B, and this week our topic is diuretic agents. You'll notice that I have placed a concept map for these in the Canvas classroom, and you might want to take a look at that. If the upper left-hand corner, you'll look at the prerequisite knowledge. There's also, I will refer to this as we go through the lecture today. There's going to be more than one audio lecture, so be sure that you capture all of those. Let's get started. So what are these diuretic drugs? Well, there are several categories of diuretics, and we're going to talk about each of those categories. But all of the diuretics are drugs that accelerate the rate of urine formation. They increase the excretion of water from the body. They cause a net loss of sodium and water. Because with sodium, in the nephron, where the sodium goes, the water follows. 20 to 25% of all this sodium is reabsorbed into the bloodstream in the ascending loop of Henle, with 5 to 10% in the distal convoluted tubules and 3% being reabsorbed in the collecting ducts. If the water is not absorbed, it's excreted as urine. Now you remember we've been studying about the kidney, and the kidney, when we think of it, a lot of times we think of excretion, but it certainly has other roles. Remember that juxtaglomerular position that we were talking about, and the role of renin in regulating the blood pressure, and the hormone erythropoietin that stimulates the red blood cell production, as well as the kidneys being responsible for the production of calcitriol, the active form of vitamin D. So when we look at the functioning of the kidneys, it's really important that we consider these things. So this slide has some numbers on it that will show you where the various diuretics work. But let's talk for just a minute about the filtration system. Remember, we learned that there's about 1 million of these nephrons in each kidney. And when the filtrate enters into the Bowman's capsule, or the glomerulus, its composition is very similar to that of plasma. Plasma proteins like albumin are too large to pass through the glomerulus, so they'll not be present in the filtrate or in the urine of healthy patients. But as the filtrate passes through the nephron, its composition actually changes pretty dramatically. Some substances in the filtrate cross the walls of the nephron and then re-enter into the blood. That's reabsorption. Water is the most important molecule that's reabsorbed in the tubule. So for every 47 gallons of water entering that filtrate each day, or about 180 liters, then 45.5 are reabsorbed, leaving only about 1.5 liters to be excreted in the urine. So glucose, amino acids, and the essential ions like sodium chloride, calcium, and bicarbonate are also reabsorbed. Certain ions and molecules, however, are too large to pass through that glomerulus, but they can still enter the urine from the blood through a process known as tubular secretion. So potassium, phosphate, hydrogen, and ammonium enters into that filtrate through that process. So examples of drugs that are excreted in the proximal tubule include some of our antibiotics, our NSAIDs. One of the diuretics that we're going to talk about today, furosemide, epinephrine is another one, and trimethoprim. So when we look at these, it's important that we keep mindful of the pharmacokinetics of many of our drugs that we're giving. Some drugs are reabsorbed, whereas others are actually secreted into the filtrate. So that's an important part of considering the side effects and the things that we'll look for in our patients as we monitor them through the nursing process. So those prerequisite knowledge categories that we have up on our mind map, a basic understanding of the urinary system, a basic understanding of congestive heart failure, a basic understanding of hypertension, and a basic understanding of fluid and electrolytes are important because diuretics are used to treat these things. We use them primarily to treat hypertension, heart failure, and fluid retention disorders. They can also be used for things like pulmonary edema, liver failure, or cirrhosis. These fall into 5 different categories: carbonic anhydrase inhibitors, loop diuretics, osmotic diuretics, potassium-sparing diuretics, and thiazide-like diuretics. So when we look at these categories here, you'll notice on the prior slide in this picture, they're listed down here in the bottom left-hand corner with little numbers, again, that tell us primarily where these drugs work. So let's talk about each category individually. We'll start with the carbonic anhydrase inhibitors. On your concept map, you'll see them listed on the left-hand side. These are things like acetazolamide or Diamox, methazolamide, or dichlorphamide. Now we know their names, but how do they work? Well, to understand how they work, we have to understand carbonic anhydrase. Carbonic anhydrase is an enzyme that helps to make the hydrogen ions available for exchange with sodium and water in the proximal tubules. The carbonic anhydrase inhibitors then work by blocking the action of the carbonic anhydrase, and that prevents the exchange of the hydrogen ions with the sodium and water. So the result of this is that when this happens, there's a reduction in the hydrogen ion concentration in the renal tubules. There's then an increased excretion of bicarbonate, sodium, water, and potassium. The reabsorption of water is decreased and the urine volume is increased. So side effects that we can get will be related to that direct action. They're typically adjunct drugs in the long-term management of open-angle glaucoma. They can be used with miotics to lower intraocular pressure before ocular surgery in certain cases, but also useful in the treatment of edema, epilepsy, and sometimes high-altitude sickness. You might want to put a little star on your concept map beside acetazolamide because it is also used in the management of edema secondary to heart failure when other diuretics are not effective. The carbonic anhydrase inhibitors are actually less potent diuretics than the loop diuretics or the thiazides. The metabolic acidosis that they can induce reduces their diuretic effect in about 2 to 4 days. So we will see as an adverse effect metabolic acidosis, anorexia, hematuria, photosensitivity, melena, hypokalemia, drowsiness, paresthesias, and urticaria. Do you remember how to play tic-tac-toe? Let's try it. Which imbalance is this? Let's read the ABGs. Our pH is 7.23, our CO2 is 46, and our HCO3, 19. Well, since we're talking about carbonic anhydrase inhibitors, if you chose metabolic acidosis, you would be correct. Let's move on to the loop diuretics. These are things like bumetanide or Bumex, ethacrynic acid or Edacrin, and our most common one that you'll see, furosemide or Lasix. You'll see these in the second layer on your concept map, just to the left of the osmotics and to the right of the carbonic anhydrase inhibitors. You'll also see torsemide there at the top. With the loop diuretics, you'll sometimes hear these referred to as high ceiling diuretics, and that's because they can cause a substantial decrease up to 20% of the filtered load of sodium chloride and water. So what does that mean? Well, as high ceiling diuretics, the loop diuretics, like furosemide, inhibit the body's ability to reabsorb the sodium at the ascending loop of Henle. So they act directly on that loop of Henle in order to inhibit the chloride and sodium reabsorption. They also increase the renal prostaglandins, resulting in the dilation of blood vessels and reduced peripheral vascular resistance. So they're very potent in their diuresis and subsequent loss of fluid. This decreased fluid volume can result in a reduced blood pressure, reduced pulmonary vascular resistance, reduced systemic vascular resistance, reduced central venous pressure, and reduced left ventricular end diastolic pressure. It also can result in sodium and potassium depletion. So because large doses of these can abolish the osmotic gradient, you'll see a very rapid diuresis. And the kidney sometimes will be unable to handle this, so it's really important that we're monitoring intake and output on these folks. And sometimes after an initial strong diuresis, there'll be a phenomenon called diuretic braking, meaning stopping, putting on the brakes, because there's this change in the osmotic gradient that's so great. We have to watch these folks for hypochloremic alkalosis and hypokalemia, because we've removed the potassium and the sodium as well as the water. And what are we going to use these for? Well, you're going to see these used with edema associated with heart failure or hepatic or renal disease. Often we use them in control of hypertension. They can be sometimes used as the first line of defense in hypertension. To increase renal excretion of calcium in patients with hypercalcemia, and in certain cases of heart failure resulting from a diastolic dysfunction. Our loop diuretic adverse effects by system with the central nervous system, we'll see dizziness, headache, tinnitus sometimes, and blurred vision. GI, we may see nausea, vomiting, and diarrhea. With our hematologic system, we may see agranulocytosis, neutropenia, or thrombocytopenia. Metabolic, we may see hypokalemia, hyperglycemia, and hyperuricemia. So you might want to put a little star by furosemide. Furosemide is our most commonly used one because of its rapid onset and very effective diuresis. It's also a weak carbonic anhydrase inhibitor. But it's important to monitor our patient because of that hypokalemia. Remember, this can cause some cardiac arrhythmias or dysrhythmias. So we want to be cautious and make sure that patients understand the side effects of these medications as well. If they're taking the loop diuretics at home, they're often co-prescribed a potassium supplement. Another thing I want to note about the loop diuretics, particularly one of the differences or a major difference between Lasix and Bumax, is that Bumax is 40 times more potent than Lasix. So it is often used in very minute amounts in situations where Lasix is going to be too hard on the kidneys. That being said, just remember that furosemide is the most frequently prescribed loop diuretic because unlike the thiazide diuretics, which we're going to talk about in a few minutes, it's able to increase the urine output even when the blood flow to the kidneys is somewhat diminished. The disadvantage of Bumax, even though it's 40 times more potent than furosemide, is that it has a much shorter duration of action. So I'm going to stop this audio lecture here. And we'll come back in a few minutes and talk about the osmotics. It's where we'll start, but they're still diuretics. See you in a few minutes.